Grand Rounds guest speaker, Dr. Joseph Hahn. Dr. Hahn holds the prestigious positions of the Chief of the Division of Allergy and Chief of Division of Rhinology and Endoscopic Sinus Surgery at East Virginia Medical School, EVMS. His academic journey starts with him earning his BS degree from University of Washington, completing his ENT residency at Medical College of Wisconsin, and rhinology fellowship at Oregon Health Sciences University, OHSU. Dr. Hahn's reputation extends far and wide, making him a nationally and internationally renowned figure in the field of rhinology. He has served as a president of the American Rhinologic Society and authored over 100 publications, actively contributing to basic and clinical research. Notably, also, Dr. Hahn has spearheaded multiple multinational, multi-institutional trials with sinusitis and nasal polyposis, including the use of biologics. Dr. Hahn's pioneering research has been a source of inspiration for many of us in rhinology, shedding the light on the science behind nasal polyps. And we are very honored to have you here, Dr. Hahn, with us to share your knowledge in a lecture entitled A Focus on Type 2 Inflammation and Chronic Sinusitis with Nasal Polyposis. Please join me in extending a warm welcome to Dr. Hahn.
Thank you, Dr. Shaban, for the invitation. So I'm going to be talking about type 2 inflammation in chronic sinusitis with nasal polyps. And, you know, the term type 2 probably was foreign to many of the ENT doctors or otolaryngologists 10 years ago. And in fact, unless you're an immunologist and do bench research, type 2 really was a foreign term. And, you know, in order for me to transition from people to understanding type 2 inflammation, I had to transition it from a Th2 and say that, you know, type 2 is similar to Th2, but it's not really the correct term. And we'll go through it. You know, this lecture has a lot of immunology. So I'm going to, you know, go through some lectures, and if there are some questions that you want to ask, feel free to ask me any of the questions, and I'm happy to kind of go through the questions and the lectures at the same time. And so these are the learning objectives of the lecture. Basically, we're going to talk about chronic sinusitis. You know, what is it? What are the different biomarkers involved? You know, what are the symptoms? You know, and what does type 2 really mean? And how does type 2 really play a role in chronic sinusitis with nasal polyps? And then talk about the comorbid disease, and I think that's important, because if you're not a bench scientist and you're looking for ways to identify these patients, you're going to have to do it with things that are CLIA approved, that are approved through the clinical laboratories, or look at phenotypes. And that's why I think it's important to know the comorbidities. All right. And so, you know, it's not surprising that chronic sinusitis, you know, this definition has kind of morphed. So in 1984, you know, the American Academy kind of came up with diagnosis. How do we diagnose people with chronic sinusitis? And I think over time, things have changed. And I think this is a pretty good definition of how do we diagnose somebody with chronic sinusitis. And if you look at these 4 symptoms, they say 2 of the 4 symptoms are indicative of chronic sinusitis. And actually, I'm going to go a step further, because, you know, when we looked at 500 CT scans, positive CT scans, and we look for symptoms that are correlated to a positive CT scans, these 4 symptoms were the top 4. And in fact, the more and more you have these symptoms, so if you had 4 of these symptoms, you don't even need to get a CT scan, because you can be sure that you got a over 90% chance diagnosis that you're going to have a positive CT scan. So these symptoms are really consistent. So when I talk to residents, you know, I tell them, you know, look, ask for these symptoms. And some of these symptoms are more associated with chronic sinusitis with polyps and some without. So if you have nasal polyps, you're more likely to have loss of smell. And if you have chronic sinusitis without polyps, you're more likely to have facial pressure or congestion. And then, you know, these CT scans and the nasal endoscopy, I know you guys know what it looks like. And so you look at the CT scan on the right, it looks like chronic sinusitis with polyps, and the nasal endoscopy with polyps. And so, and like I said, if there's any question, feel free to ask me any questions as we're going along. Now, you know, SNOT-22, for what it's worth, you know, there are different variations of SNOT, right? There's SNOT-25, and if you ask Jay Piccarello which SNOT he likes, he likes SNOT-31. And so, but the one that seems to kind of hold the most common one that's being used is SNOT-22. Now, actually, SNOT-22 didn't include, it wasn't actually a SNOT-22, actually it was SNOT-20. And then they made a SNOT-22. And you know what symptoms they had to include in there? Nasal congestion and loss of smell. And so, and in fact, those are the two best predictive symptom of chronic sinusitis. And so if you ask your patients, you know, what's the most common symptom? Nasal congestion is the most common, followed by loss of smell, especially after. And it's actually interesting if you ask, and you know, and it varies based on culture, right? So if you ask the people in the US with chronic sinusitis with nasal polyps, what's the overriding symptom? What drives a lot of your, you know, treatment, you know, is nasal congestion. But in Europe, it tends to be loss of smell. Loss of smell is the driving force to, or the driving symptoms and what they want to change in treating our patients with nasal polyps. And so these are the different symptoms, and what you see is that the symptoms are consistent. So, and you know, and that's how you know that where the truth lies, because when you have, you know, people who write certain papers, and we know that over time, some of those things that we write in a paper tend to not be as true as we'd like it to be, but if you have more and more papers say the same things over and over again, you know that's probably going to be the truth. And I think what you see is that more and more people say congestion, pressure, drainage, and loss of smell are very classic symptoms of chronic sinusitis problem. If you ask, the fifth most common symptom, if you're interested, is loss of smell. Oh no, loss of sleep. Loss of sleep. And it makes sense because when you can't breathe through your nose, you can't sleep. So let's talk about chronic sinusitis with nasal polyp and how type 2 kind of plays a role. And so, you know, the reason why we say that most of chronic sinusitis nasal polyp is driven by type 2 was written by Whitney Stevens, who really did a good job in looking at endotyping these patients. And what she found out is that 80% of CRS with nasal polyp is driven by type 2. So what does that mean? And let me kind of go through that. And so when you talk about type 2 inflammation, and I'm going to go into a little bit more details, but if you talk about, you know, what are the driving forces of it, certainly allergy plays a role. And I think when a lot of people think about type 2 or Th2, allergy kind of plays a role, right? You're talking about T helper cells, you're talking about IgEs, you're talking about eosinophils, mast cells, and such. And I think what plays a bigger role, and I think we're starting to understand that it may be the driver, is the epithelium. And so a lot of these diseases that we talk about, the respiratory diseases, I think we're starting to realize that epithelium is playing a more important role than we thought in the past. And then certainly, if you look at nasal polyps, you know, and you're looking at inflammatory cells, and you know, which is what we did, the most common and the prevalent inflammatory cell is eosinophils. And so, and again, like I said, if there's any question, feel free to stop me. I love this stuff, but I know not everybody, especially ENTs, don't like it. But I do love it, and so I'm happy to kind of explain things as much as you guys want. Now, you know, it's kind of interesting, you know, when we're looking at what drives nasal polyps, you know, we were looking at the different inflammatory cells. So these are things that, you know, I started back when I was teaching at University of Virginia. We had gotten a couple of NIH grants looking at, you know, what drives nasal polyp? How is sinusitis related to asthma? And so we were looking at a lot of different cytokines, and the three cytokines that, you know, just are are the most prevalent is IL-4, IL-5, and IL-13. And those are the inflammatory cytokines associated with type 2 inflammation. And IL-4 and IL-13 is really important, especially for allergic diseases, right? Because IL-4 is responsible for class switching of the B cells, right? So in order for the B cells to become plasma cells and make the immunoglobulins, you need IL-4. And, and that's why, there were concerns about, when COVID came around, and we were giving the COVID vaccine, they were worried that will dupilumab affect the efficacy, or if you block the IL-4, if you block the IL-4, would you affect the efficacy of COVID vaccine? Now, and the reason for that was because of this class switching process, but it turns out that it did not. But that is, one of the things that you have to think about. So when you understand the mechanism of how things occur, you have to worry about whether or not it's going to affect different treatment options. So IL-4 and now, especially IL-4 is really important for the class switching of B cells into plasma cells to make the immunoglobulins. And the IgE specifically binds to the basophils and mast cells, which then trigger the allergic reaction. Okay. And then if you think about eosinophils, and you're thinking about what inflammatory cytokine goes hand in hand with eosinophils, it should be IL-5. So when you're thinking IL-5, eosinophils go together, eosinophils and IL-5 kind of go together. And the reason why IL-5 is so important is it allows for the maturation and the transport of the eosinophils from the blood cells into from the bone marrow into the blood cells. But it's IL-13 that brings the blood eosinophils into the tissue. And so without IL-13, you can't do that because IL-13 is responsible for the production of eotaxin, and eotaxin is then allows the delivery of the eosinophils into the tissue. So IL-4 and IL-13 definitely play a role in eosinophils and tissue eosinophils especially. Does that all make sense so far? Right. And one of the most common comments I get after I give a lecture is during the lecture, they say, oh, all this immunology stuff makes sense. Then they see me a couple of days later and they go, we completely forgot what you said and it doesn't make sense anymore. But I'm hoping to make it easy for you and make correlations. And I'm going to say bad and good just to make things easy. All right. So now this was a study, this was a cluster analysis of endotypes. And this was done by a group of European rhinologists. And, they got together and they looked at patients with chronic sinusitis who had undergone sinus surgery, and they looked at the different endotypes. And so what they looked at was IL-5. And, as we talked about before, IL-5 and eosinophils kind of go hand in hand. And we know eosinophils kind of go with chronic sinusitis, especially nasal polyps. So what they did was they measured IL-5 and IgE. And we know IgE is a very important biomarker for sinusitis and asthma. And ECP, which is eosinophilic, it's a eosinophilic biomarker, is also there. Now, when they looked at that, they found 10 cluster analysis. So they found 10 groups, but really, you could really break it down to 3 groups. One on the top, which doesn't have a lot of IL-5, and the other 2, which has IL-5 in there. And then what you see is that that the ones on the top that don't have IL-5, that have sinusitis, usually don't have asthma. The ones in the middle have a higher prevalence. IgE is a factor, and the ones on the bottom, IL-5 is a bigger factor, and eosinophil is a little bit bigger factor. And so what does that mean? So the top third is probably CRS without nasal polyp, where IL-5 probably isn't playing a role. So this is kind of like the CRS without nasal polyp patient. Now, there is some variations of it, but that's what we have. And then the one on the middle is patients with nasal polyp that don't have asthma. And so these are ones that are typical patients with allergic rhinitis, have nasal polyps, and usually don't have asthma. And so these are people that are more likely to be men, right? So So the middle group is more likely to be guys, and that's why we see in our patients with our dupilumab study, or when we look at all our sinusitis with nasal polyp studies and biologics, we find that majority of the people with nasal polyps in the biologic studies, regardless of which biologics you use, majority of the people tend to be men. And so that's that middle group. And then the bottom group are patients with where asthma drives everything and nasal polyps are there. And these patients are the ones with the severe type 2 inflammation. And so these are more likely to be the women. And so that's why when you have biologic studies looking at asthma or severe asthma, we know that 60% of the people, majority of the people, tend to be women. So the one on the bottom third tends to be more women. Now, after they published this paper, I was having dinner with Klaus, who kind of helped, spearhead this stuff, and he's been great. He's kind of retired. You could tell I'm old because most of the people I know are old. They're about to retire or they're retiring. And just to let you know, Raj Chandwani is the same age as I am, so he's old too. And so we were rhinology fellows at the same time. And so Klaus Bachler, who's retired from University of Ghent, I had dinner with him and I said, hey Klaus, this was a great paper, and I'm glad you got together with a lot of the rhinologists and kind of came up with this paper, because I think this is really the right path that we need to go, and I told him this was an extension of my trialogic thesis, but I don't know if he agreed with that, but I thought it was. And so, and I said, I'm kind of curious, why didn't you look at IL-4? Because IL-4 is a big factor, and so is IL-13. But IL-4, I think, is a really big factor. And he said, oh, it's not that we don't think IL-4 is important. We just couldn't find it. And that's the truth. Because, when we did our trialogic thesis looking at IL-4, we were able to detect it. And part of it was I was a little bit of a taskmaster. I had research. And I think, well, I say that to be funny, and you guys don't laugh because maybe there's a lot of people in Cleveland Clinic that are taskmasters. But so like for me, fortunately, I had a lot of research assistants that didn't mind working late at night. And so I would collect nasal polyp specimens during the daytime. I would give it to them. They would process it that night and measure the intracellular cytokines, because the amount of IL-4 tends to be a little bit low. They're hard to detect. And so because of that, we were able to detect it. But, it's not that they didn't think IL-4 was important, but they just couldn't find them. And that's what you're going to find. And so a lot of people have tried to find IL-4, but it's been hard to detect. And so we're one of the very few labs that were able to detect it. And so IL-4 is definitely a factor. And if you looked at where the second group and third group, IL-4 would definitely be present in those patients. So, the other things to kind of think about is, as we said earlier, is eosinophils, right? So if you had to pick one inflammatory cell that is responsible for nasal polyp, eosinophils should be on the list. The only other inflammatory cell that seemed to be an important factor is mast cells. So that was the only one that was statistically significant when we were looking at these inflammatory cells. But when you're looking at so here what they're looking at is eosinophil aggregates. So these are looking at eosinophils within the eosinophilic mucin. When you see those patients with nasal polyp and then you're suctioning those and you're getting that glue out. Do you guys get allergic fungal sinusitis here? Not much. Yeah. So, that's what you see with allergic fungal sinusitis. You're pulling it out. There's these thick eosinophilic mucin, and you're suctioning the mucus, and you're seeing it. It's like glue, and it stretches like 3 or 4 feet. Yeah, that's eosinophilic mucin. And in there are lots of eosinophils. And so when they looked at, these mucin and to look at high levels of eosinophil aggregates, what you see is that it's higher risk of revision surgery. And in fact, I would say, if you have high tissue eosinophil, is a very good predictor that you're going to need surgery over and over and over again. And now the question is, does blood eosinophils and tissue eosinophils go hand in hand? And I would say the initial, and if you read some of the papers, including my paper, it shows that there really isn't a good correlation. And I think part of the reason is I think we did that when we did that analysis, we did it wrong. And I think if you look at the extreme versions, I think you'll find that there is probably a correlation between blood eosinophils and tissue eosinophils. But at the lower numbers, there doesn't seem to, or if you look at it all together, it doesn't seem to correlate very well. But what the eosinophils also kind of correlate to is higher use of systemic steroids. And so not only increased number of surgery, but increased need of systemic steroids. And so remember I said earlier that I thought that the epithelium is important, and I think we're starting to realize that more and more, and you're going to see more and more research papers showing that. And so before I go to the next section, I'm going to stop and ask any questions. Let's see if anybody has any questions. Does that all make sense, right? Yeah.
Hey, Joe, where does, particularly with the allergic chronic sinusitis patients, how does IgE fit into that? And were you measuring it in the context of worst nasal polyps and those things?
Yeah, and so it's actually interesting. So I'm going to give a talk at the Quad AI, and they asked me to give that exact same lecture. How does IgE play a role in chronic sinusitis? And I would say, Mike, you probably travel more than I do, and you're probably more internationally well known than I am. But I am starting to follow in your footsteps and give a lot of lectures internationally. And so when I went to the Middle East, like Saudi Arabia, Qatar, Dubai, eosinophils over there is very important for them as a protective for parasitic infection. But in the US, parasitic infection is not that big of a deal. So, eosinophils is important there. Now, IgE is another one that I think is really important for showing that people with high IgE can have more severe disease. So the higher the IgE, the more. So this is just in the US. And so what we find with IgE in the US may be different than what we find outside the US, is what I'm trying to say. And so in the US, if you have high levels of IgE, it seems to correlate with more severe sinusitis and asthma. And so let me say it another way. So if if you have patients with nasal polyps and asthma, and you're trying to figure out, how bad is their, can you predict how bad it's going to be? One of the things that I measure is IgE. And if the IgEs are really high, and I see IgEs as high as 1,000 or 3,000, that tells me that, that probably may be the driver for a lot of the asthma nasal polyps. So I try to target that. And so, and that's what the studies are showing. But again, outside the US, you don't really see that pattern. So if you're trying to diagnose somebody with atopic disease, you need to measure specific IgE, not total IgE. But if you look at total IgE in the US in general, if it's high, if it's greater than 100, you're more likely to have atopic disease and more likely to have atopy playing a bigger role. So I do think that IgE is important. But we need to do a better study looking at that. Troy?
Yeah. Hey, Joe. Do you routinely check like CBC with diff and IgEs with every patient, or how does that modify your treatment?
Absolutely, so I don't know. So it's actually interesting. Traveling internationally, I'm finding out several things. So in the U.S., people talk about ICAR, right? The International Consensus of Allergy and Rhinosinusitis is sponsored through the IFAR, and a lot of the ARS members are responsible for a lot of those articles that go through there. And so outside the US, they refer to EPOS or euphoria. And so the EPOS is the European position paper. Is really run by Whiskey Folkens, who's a good friend of mine, and she's also retired too, or she's retired. And so she kind of runs that. And then Peter Hellings is the one that runs Euphoria, and they talk about, and so Euphoria is this really nice European group that made up of allergists, immunologists, ENT doctors, and pulmonologists, and they write different articles on what they experience. And so being part of both of those organizations and papers, one of the things is we ask that same question. So should we be measuring CBC with diff, and should we be measuring IgE? And the answer seems to be yes. And the reason for that is because, if you don't have a lab to do a 10-color flow cytometry looking for IL-4, you're never going to detect IL-4, or you're never going to be able to show that, or even IL-5 or 13, or even, and if your pathologist doesn't even want to measure tissue eosinophils, you're not going to get that, right? The information. And so by having the things that are CLIA approved, the things that are readily available, you can use that to diagnose if someone has type 2 sinusitis. So what we said in the Euphoria paper is that if your blood eosinophil is greater than 250 and your IgE is greater than 100, we would consider that sinusitis patient as having a type 2 disease. Now, I didn't necessarily agree with all that, but I got overruled. And so the majority of the people said that we wanted to do that. And the reason why we wrote it that way is because, having written a lot of evidence-based papers, whether it be through the Academy or through the ARS, what we find out is that even though our message for that paper is for the physician and to provide physician guidance, what we're finding out is that the people who really use it are the insurance companies to restrict treatment options, right? And if you're a practicing clinician, you know exactly what I mean. If you're a resident, you'll know what I mean, because it's miserable. And so when we write these papers, we have that in mind. We know that the insurance is going to twist that information around and restrict treatment for our patients. And so that's why we set the bar low. And we said, and in the US, it's probably most experts in the US would say blood eosinophils greater than 300, not 250, greater than 300, and IgE greater than 100. In Europe, it's 250 and 100. So if you have that, then you could say that they have type 2 disease. And that's how you can kind of label it. But we know that you probably need to have higher numbers, because what we're seeing is that people who are looking at the Euphoria guideline and the EPOS, like I just gave a talk in Brazil, came back from Singapore, and what they are doing is looking at the EPOS and Euphoria guideline and using that to do clinical studies and finding out it doesn't seem to match up. And the reason why it doesn't match up is because we set the bar low on purpose to try to get the treatment options available for our patients. And so the answer is yes. So the short answer is yes, the long answer is what I just gave you. And so, yeah. Any other questions? And I'm not intimidating. I'm actually a nice guy. So, I won't bite you if you ask me questions. Now, so, I think what we're realizing is that epithelium is important. And the reason for that is because when we look at the epithelium, and it's for sinusitis specifically, when we look at the epithelium, we know that when there's a problem, the epithelium is destroyed. It's not the normal pseudostratified ciliated epithelium. It becomes transitional cells. It becomes squamous cells, and there's a lot of problems with the epithelium. But the good news is when we reverse it with the right medicines or with different treatment, the epithelium ends up being normal. And so that's how we're starting to realize that, boy, epithelium is playing a bigger role, and I'll tell you why. And remember we said, type 2, Th2 is probably a misnomer now. And the reason for that is because, you know, if we're talking about Th2, we're thinking about allergy disease, right? Allergens causing problems in the epithelium, and then the epithelium just releasing three different alarmins. So TSLP 25 and 33, and I think what we're and so those are the three alarmins that get released from the epithelium, and from there you get, you know, release of IL-4, IL-5, and IL-13. Now, what we're realizing is that it's not just allergy that causes inflammation in the epithelium. We can also have viruses doing that. We have irritants do that. And it's not going through the normal adaptive immune system going through the T helper cells, but they're going through other cells called innate lymphoid cells. So ILC2 also make IL-4s. And so because of that, we can't say it's a T helper cell anymore. So that's why we call it type 2 inflammation. But it has, so a lot of the stuff that are going through the ILC2 are a lot of the same things that we're seeing going through the T helper cells as well, T helper CD4 positive cells. And so we know that whether it be, and, you know, like if you have a patient with, you know, they'll say, oh, I get a cold, and then I have an acute exacerbation from my sinusitis. Well, this is exactly the mechanism, is the viruses like rhinovirus especially causes injury to the epithelium, and then it releases the alarmins and causes the cascade to occur. And so like, you know, I mean, I don't know, you guys probably see that, right? You know, during the winter time, they'll have a viral infection, and they'll get acute exacerbation for their asthma and their sinusitis. Well, this is it. And so it's not just the bacteria that causes that. And so we know that, and this is kind of the looking at the different integrity of the epithelium. So looking at gap junctions and the gap junction proteins. So when we're looking at the lower and upper respiratory system, you see that that IL-4 is bad. So let me say that again. IL-4 is bad because it causes a lot of problems. I think we're realizing that IL-4 causes problem with smell in the animal model. We're realizing that IL-4 is bad in causing destruction of the epithelium and the gap junction integrity. And so let me say that again. In general, IL-4 is not bad. And in fact, we need IL-4 and IL-13 to help fight off infection and stuff. But when it's uncontrolled and it's elevated, IL-4 and IL-13 are bad and causes more problems than we should have. And so, so that's what this is showing us. So what it's showing us that if you have IL-4, it decreases the integrity of the epithelial junction, and that's what is showing here through the JAMA and the E cadron. And so, so if you have IL-4 and IL-13, it destroys those gap junctions, which is important because when those integrity of the epithelium is destroyed, all these irritants and viruses and bacteria can go through the epithelium and causes swelling and causes problems. And then, you know, and one of the, so one of the, a lot of people are trying to understand, you know, what causes the polyp. And you know, if you see patients with nasal polyp, where do they usually occur? Osteomiddle complex, right? Around the ethmoid, posterior ethmoid, olfactory group. They never occur in, they rarely ever occur in the uncinate. They almost never occur in the inferior turbinate. They almost never occur in the floor of the nasal cavity. So the question is why? Why is polyp specific to certain sites? And I think one of the answer may be TPA, tissue plasminogen. And actually the person who did a lot of this work is Bob Schleimer. He's also retired as well. So a lot of people that I'm talking about, you could say that I know that are retiring. And so again, that's why I'm old. And so what he found out is that if you looked at tissues that have high tissue plasminogen, they don't tend to have polyps because the plasminogen is responsible for the degradation of the fibrin. And when you have high tissue plasminogen, you're not going to get polyps. But if you have low tissue plasminogen, you're going to develop polyps. And so that's what he did. So when he looked at patients with CRS and without, he showed that people who had low tissue plasminogen tend to have more polyps. And so that's what is showing here. And so if you're trying to wonder, how does tissue get made? The macrophages release the cofactor 13. The cofactor 13 then causes the fibrinogen. The fibrinogen that gets activated to fibrin, cross-link those fibrins together. And then with the epithelial destruction and the exudates that form, you get the swelling and you get the polyp formation there. So that's how tissue polyps are made, as we know. Now, we may find more stuff, but for now, I mean, that seems to be the driving idea on how nasal polyp gets formed. So TPA is good. So if you're trying to figure out, is TPA good or not, it's good because it helps get rid of the polyps. And then here we're looking at, with patients with nasal polyp, we get that eosinophilic mucin, that thick mucus that we see. Well, what's driving that? And I would say what's driving that is IL-13. IL-13 causes global hyperplasia and it releases all the mucin that you see here. Not so much IL-5. And IL-4 is definitely there, but it's really IL-13 is what drives those thick mucus that we see in our patients with nasal polyp. And then here are looking at so this is Klaus's work from Ghent, and and he's got this and I'm not saying it's wrong, but I don't think it's specific to Staph aureus enterotoxin. But what he's showing is that if you have patients with nasal polyps, if you give them Staph aureus enterotoxin, you see increased levels of IL-4, IL-5, IL-13. But I think you can also see that with rhinovirus, and we've seen that in patients with, if you do patients with asthma and you give them rhinovirus, you see these things elevate as well. And I think, Pseudomonas and any other bacteria can also cause similar responses as well. So this is kind of talking about what we talked about before. You can have an insulting agent like a bacteria or viruses, and it can trigger the epithelium to then cause inflammatory cascade. And that's what we're seeing here. And so with that, I'll stop and see if there's any questions. That was a lot of immunology. So did that all make sense? Right? Everybody's nodding their head. So, okay. So everybody, okay. Yeah.
All the time. If the epithelial barrier is a problem in most of these, why do some patients smile and they have asthma all the time? I mean, is it the same epithelium? Why some patients don't have asthma? I mean, I just couldn't have an explanation so far. Why only in nasal? They get this stuff.
Yeah. Yeah, no, and Mohammed, that's a great question. And, and that's what we're trying to figure out. And I think that's where epigenetics plays a role, right? I think that's where genetics plays a role and the environment plays a role. And so for those who don't know, so my parents were from Korea. And then we have and so I was born in Queens, moved throughout the US. So I went from Queens to Phoenix to LA to Seattle to Philadelphia to Milwaukee to Portland and then Charlottesville. Now I'm in Virginia Beach. And so I lived kind of everywhere. And one of the things that was really interesting for me is I have bad food allergy. My daughter has peanut allergy, and I was stupid. This is before the LEAF study. So I said peanut avoidance, right? And but and that was a bad mistake. I should have given her peanuts earlier on. But when I went to Korea, and I usually give talks there once a year, and when I went there, peanut allergy is like non-existent. And so when we were, I took my family there, and we were out in the streets, and we wanted, my daughter wanted a donut. It had peanuts on top, and we said, "Hey, do you have a donut without peanuts?" And the street vendor said, "Oh yeah," and she got the donut with the peanut on there, brushed off the peanut, and then gave it to me. And we said, "Oh, I don't think you understand. It doesn't work that way." And so one of the things that I asked is, why is it that peanut allergy is non-existent in Korea And while in the US, among Korean Americans is almost as high as the US population. And so it has to do with the genetics and the environment. And so in Korea, I think the way they eat it is they boil it most of the time. In the US, we roast it. And so it's a temperature high enough to destroy all the ARA proteins. I don't know. So I think that may be a factor. But what you see is that the percentage of allergic rhinitis in Korea is about 14. But when you look at the prevalence of allergic rhinitis in Korean Americans, and when they come to the US, it starts going up to about 17%. And so all of a sudden, that's where the genetics and a little bit of the environment plays a role. And so I think, and not to say that the short answer is I don't know. But the long answer is I think we're starting to figure out that it has to do a little bit with gene and susceptibility and environment. So like, for example, aspirin triad. If you look at patients with aspirin triad, 90% of the time is spontaneous, right? And while if you have allergic asthma, having one family increases your chance from 17 to 30%. And if you have two parents, it increases it to 50%. So genetic plays a role. And so certain disease, genetic plays a role, certain disease is not a role. And I am positive that people with aspirin triad or ARD or NSAID ERD, depending on where you live and what your specialty is, I think is triggered by a virus. I'm not sure which virus, but I think it's a virus. And Tom Plasmo, who's also retired from UVA, I don't know if you know who he is. He did all the work on alpha-gal. Yeah. So red meat allergy, and so he and I, we were working together and with Larry Borish, and we were talking, and he said, he asked a lot of interesting questions. And one of the things that before he finalized everything is like, I've been seeing patients with red meat allergy, and they swear they have it, and there's this really one famous person that he saw that had this red allergy, which is what made him look at all this stuff. And so when he said that, people thought he was crazy, but now it's like everybody talks about it, right? And so I'm gonna say aspirin triad is triggered by a virus. I know that sounds crazy right now, but I think just like it's something, some virus gets primed and then causes the aspirin triad to occur. And I think that's what's driving the aspirin triad. So I think it has a little bit with genetics and a little bit of the environment that causes that. So, all right. Any other questions? All right. So, all right. So I think this part is the part that I think is going to be a little bit more clinically relevant for you guys. So so here you see on top NSAID ERD. That's same thing as ARD. So if you're European, you said NSAID ERD. And in fact, they actually called it NERD. And I said, hey, that doesn't sound very good for Americans because that's associated with a derogatory labeling. And so then that's why they called it NSAID ERD. If you're an allergist in the US, you call it ARD. And if you're an ENT doctor, you call it aspirin triad or Samter triad. Same thing. And so if you're looking at, how many of our patients with sinusitis have ARD or aspirin triad, I'm going to say aspirin triad says I'm talking to a group of otolaryngologists, it's about 10%. So if you're wondering, how often is it, it's about 10%. If you ask my practice, what percent of my patients have aspirin triad, it's about 30 to 40%. So it's higher. And I think in Cleveland Clinic, you're going to probably have the same number. It's going to be about 30, 40% of your patients will have ARD because they tend to come to these areas. And a lot of these patients have ARD and they're undiagnosed. And so let me kind of tell you a story. So I had a patient, bad nasal polyps, and asthma was bad, but it was well controlled with ICS/LABA, high-dose ICS/LABA. This is before the age of biologics, and he had polyps, and they just kept on coming back. And his wife was a nurse that worked at our hospital, and I see her almost every day. She's saying, "My husband's miserable. Why can't you fix him?" We did surgery, and we did surgery, and the polyps kept on coming back topical steroids and you know, everything you can think of, and it just wasn't getting better. And so then, you know, so he would just come in every 3-4 years and have surgery over and over again. And I felt miserable because I saw the wife saw me and she knew I was doing my best to take care of this patient, but you know, I just wasn't doing a very good job. And so one time he came in and he said, "Oh, hey, you know, my polyps and this and that." And I said, "Oh," and I did ask him, you know, what happens when you take aspirin? He said, "Oh, fine." And so one time he came in and he said, "Oh, hey, I went to the emergency room." I said, "Why'd you go to the emergency room?" He said, "I went to the emergency room because I was playing basketball. My knee hurt, so I took Motrin, and then I had an asthma attack, so I had to go to the ER." I said, "Oh, well, how often did that occur?" Twice. I said, "Oh, you have aspirin triad." He goes, "What? I have aspirin triad?" Well, you know what? I've been following him for like, you know, 7 years. And for those years before, he could take aspirin and Motrin without any problems, but something triggered it. And then all of a sudden he became aspirin intolerant. So how do you not make the same mistake? And we have about 10 patients that we've been following along that were aspirin tolerant in the beginning and became aspirin intolerant over time. And so how do you know who they are? Well, I'll tell you who they are. And Sally Wenzel did a really good job looking at phenotype cluster analysis and kind of showed that. And we're seeing the same thing because we measure urine LTE4 in these patients, and we're finding it that they're almost as elevated in patients with ARD. So who are these patients? These are patients with adult onset asthma, late onset asthma. So they develop asthma not as a kid, but they develop it later on. And they usually don't, that doesn't mean they don't have it, but they usually don't have a history of allergies. So they didn't have allergies as a kid, they don't have allergic asthma as a kid, or they don't have atopic dermatitis. They usually have non-allergic disease. And so when you're doing specific IG and total IG, it's usually not that elevated. The eosinophils could be elevated. And so these patients with late onset asthma that usually don't have a strong allergy picture, these patients, I tell them, stop taking NSAID, and I start giving them a 5-FAAOA inhibitor, and they usually do better. So if I had known that, I would have given them a 5-FAAOA or a cis1 receptor antagonist inhibitor at higher dose, and it would have helped them. And that was in the area before biologics. Now we place him on a biologic, and he's much better. And so, so those are hi, somebody from the virtual forum. And so, hey, do you have a question? All right. So then, you know, allergic disease causing asthma, nasal polyp. Well, we're not surprised by that, right? Because I mean, Whiskey Folkens did a great job looking at that, right? So if she had patients with allergic rhinitis and asthma, and she put an inhalant allergen in their nose, what happened to their asthma? It got triggered, right? And so that's kind of what we did. So that was one of our NIH research was, you know, how does asthma and sinusitis kind of go hand in hand, and we're finding the same thing. So this whole unified airway disease. So we work with Jack Krause, and I'm not even sure if he's working anymore. He was a chair at Temple, then he went to be a dean at Texas somewhere, and I think he's again retired maybe. But you know, so he helped me. He asked me to help them write about this unified airway disease, you know, and so we did that. And so it's not surprising that people with allergy and asthma kind of go hand in hand. And you know, allergies plays a bigger role. Well, so let me say that again. People with nasal polyp have a higher incidence of allergic rhinitis. Higher incidence. 70-80% of people with nasal polyp have allergic rhinitis, but it's probably not the best predictor of nasal polyps. So if someone has allergic rhinitis, I'm thinking of nasal polyp and sinusitis a little bit. But if they have asthma, I definitely think of sinusitis and nasal polyps. And in fact, you know, I've been very fortunate. I've been giving talks to allergists and pulmonologists, and the lectures I give to the pulmonologists about sinusitis is I'll say, if you have a patient with asthma and they have any kind of nasal symptoms, you should be thinking of sinusitis. And if they lose their sense of smell, you should be thinking about nasal polyps. And to the pulmonologist, like a mind-blowing thing. Like for us, like, oh yeah, that makes sense. But to the pulmonologist, like, oh my God, like I can't believe I didn't even know that. And so, but it's true. I mean, so they all kind of go hand in hand. And asthma being a big factor. And so, and if you look at these H&E staining, we can see that the epithelium is destroyed. And so a lot of this picture are pictures that I did, because the person Stanky and Larry Borish, those are my pictures. And so we looked at the epithelium because we saw that the epithelium got changed. And so definitely remodeled. And so when you fix their disease process, the epithelium tries to come back to being normal. So that's why, this whole idea of reboot surgery, I don't like. And you hear it in Europe and outside of Europe, but I don't like it because, I think if we can intervene through other means than the surgical, we can allow the epithelium to kind of come back to being normal. And we have those options now that we didn't have before. And, and so this is a talk that we give to the pulmonologist, and we say that if they have nasal polyp, the reason why it's important for you, to the allergists or the pulmonologists who are taking care of asthma, the reason why it's important for you is because if you have nasal polyp, you're going to have worse outcomes. They're going to need more hospitalization. They're going to need more ER visits, more steroids, and that's what it shows. And so we see that if you have asthma with nasal polyp, you have higher blood eosinophil counts, you have higher pore control of your asthma, and your FEV1 is lower as well. And I think, I know we talk about, different ways of measuring asthma. A lot of people look at acute exacerbation, but I think FEV1 is actually still a pretty good predictor. And if you look at FEV1, clearly the people with nasal polyp have a worse FEV1. And this is for us, I think this is important to kind of understand. If you have CRS with nasal polyp, you're going to have a worse outcome. So if you don't have nasal polyp, but have plus or minus asthma, the chance of you needing revision sinus surgery if you have asthma is 5 times. So if you did sinus surgery and the patient has asthma compared to those who didn't have asthma, you're 3 times more likely. So let me say that again. I probably didn't say that as well. So if you have nasal polyps, if you don't have nasal polyps and you have asthma, and compared to those who don't have asthma, you're 5 times more likely. So asthma is a good predictor. If you have nasal polyp and you have asthma, the ones who have asthma are 3 times more likely to have it. And we see people with ARD, which we know who are the worst of the patients with nasal polyp, are 2.5 times more likely to need surgery than those with polyps and asthma. So again, what this is telling you is if you have asthma, you're going to have a worse prognosis. You're going to need more surgery, and most likely because these people have higher inflammation going on, and that's what it's really telling us. And so we know that, again, this is another example of people with aspirin triad having worse prognosis. So having a higher CT scan and higher worse quality of life measures. And then here we're showing patients with aspirin triad needing more steroids. And then you look on the steroid dependent disease. You know what's interesting there? All right, so so look at that graph on the right side, your right side. So if I'm gonna ask you a question, who do you think writes the most prescription for oral steroids? Allergists, pulmonologists, or ENT doctors? And that table tells you what the answer is. You're right, it's ENT doctors. And then actually, so when we were doing a big data analysis, looking at the health population and the severity of disease and the different medications, what we're finding out consistently is the people who write systemic steroids, oral steroids, I thought the highest would be among pulmonologists, but we're wrong. It's actually among ENT doctors, and that's what that study shows. And so we're seeing that patients with sinusitis with nasal polyps are more likely to get steroids than people with asthma. And why is that important? And I would say, Michael Poole, Mike, you would know who he is, right? Yeah, so UT Southwestern. He used to be the chair of UT Southwestern, and he's retired too. And so, right, and so what he showed, and he was the biggest champion, was overuse of antibiotics. And I think a lot of the rhinologists are now saying overuse of systemic steroids. And I think overuse of both of these things are bad. And that's what, when you have acute exacerbations, you're going to use more antibiotic and steroids. So you got to avoid it. So why is this so bad? And this is a study from UK, from Price, who showed that the higher use of systemic steroids, the more likely you're going to have complication. And it starts at 1 gram in their whole lifetime. So that's only 2 or 3 doses of systemic steroids, and all of a sudden you're hitting 1 gram. And so that's why we really try to minimize it. So, all the EPOS and the Euphoria people, the rhinologists, we sat down, we said, how much do we say is too much? So for antibiotics, we'll say 3 or 4 in a year is too much, right? For sinusitis. What about for systemic steroids? And we don't have a good answer for that. But, our opinion is, if you're doing more than 2 times a year, it's probably too much for systemic steroids. But that's just expert opinion. We don't have a good solid number. So basically don't use systemic steroids if you can. And if you're going to try to use something else like topical steroids or other methods of substituting the systemic steroids, because systemic steroids causes problem. And so in conclusion, I think, I hope that you understood, what chronic sinusitis with nasal polyp is, what's driving it, looking at the comorbid disease, looking at the different biomarkers, and hopefully looking at all those big pictures together, we can probably come up with a more targeted treatment on how to treat our patients with nasal polyps. So with that, I've got a couple of minutes for any questions. Yes.
Fantastic, and it actually is kind of fun to listen to this stuff from someone who's truly an expert. A comment and a question. So number one is we've actually shown that specific IgE and class of response, you can create a phenotype if they're allergic to dog, dust mites, cats, and have a high class response over poorly controlled asthmatic patients.
Yeah.
High ED visits, hospitalization, steroids, etc. I think the other question was more related to how do you build this entire inflammatory model into a clinical picture for treatment? I mean, I think you showed that if you measure these particular things,
Yeah.
that we're going to be able to identify the higher risk patient.
Yeah.
But we did a study that showed what you call the reboot surgery.
Yeah.
That actually,
Yeah.
and so did Clay Hopkins, that if you did surgery really early
Yeah.
in an
Yeah.
asthma-prone
Yeah.
patient,
Yeah.
and didn't treat them
Yeah.
medically until their sinusitis with chronic sinusitis,
Yeah.
that they actually do better and don't develop asthma.
Yeah.
Where does that
Yeah.
fit in? I can see the multiple surgeries
Yeah.
may not be the way to go, but
Yeah.
I think that if we get these people surgically earlier,
Yeah.
we reduce that kind of asthmatic inflammatory cascade.
Yeah, no, absolutely. Great point, Mike. I mean, you're absolutely right. I mean, that paper that you and Claire wrote about early intervention is so key because the earlier we intervene on these patients, the better the prognosis in the future. And the reason why Claire wrote that paper, I asked Claire, why is it that you write that paper? She says, because in Europe, it's actually interesting. When in the US, if you want to see a specialist, you just get referral from your people, and it's pretty easy. Or sometimes you don't even need referral, and you just come in. So like a third of my patients are referrals from other patients because they have sinus disease, they need to get good care. So the patients will say, "Oh, you need to see Dr. Han, because if you're not getting better, you need to see Dr. Han." So actually, a third of my patients, I don't even need referrals, and I'll just see them. But the reason why she did that was because I don't know if you're having the same issue here in Cleveland, is because the primary care doctors hold on to them because that's how they make money. And so they'll hold on to them, treat them, because every time they send a specialist, they'll lose money. So they were holding on to them. And so she was so frustrated, she wanted to say early intervention, just like you wrote. Early intervention helps with the treatment. And I know this is very unconventional, and when I, I'm going to say some things that are going to be a little controversial, but I hope you take it for what it's worth. When I operate on patients, I operate on patients on who they're going to be, not who they are now. So and the reason why I do that is we were looking at our cystic fibrosis patients at UVA, and we were looking at, all the CF patients that we were doing surgery on, what happens to these patients. And, most of the CF kids before Trikafta, was of the CTFR stabilizer, were miserable patients, and they died young. And they're miserable with their sinusitis. All CF patients have 100% have sinusitis. So we would operate, and, being kids, I thought what you had to do was the minimally invasive one. So open up the osteometal complex, maxillary anterior ethmoid, and then if they don't get better, then do the total ethmoid and sphenoid, and then eventually do the frontal. What we've found over time is that these CF patients needed surgery again and again. And so this is kind of where I started talking to Brad Woodworth. And he said when he treats the CF patients, if he does surgery, he does one big surgery. He does the maxillary megaantrostomy, the Lothrop at one time. And well, you're from Alabama, right? Yeah, right. Brad would say that, right? And so I mean, and that's what he does. And I think in the same fashion, if I have patients with that I know that have ARD, and even though they may have just disease in the maxillary and the ethmoid, not necessarily in the sphenoids and frontal, I will open up the maxillary, ethmoid, sphenoids, and frontal, because I know in my experience that they will come back 3 or 4 years later and have disease in the sphenoid and frontal, and I didn't operate on that, and I feel like a failure. And so a lot of allergists and pulmonologists say, "Oh, you ENT doctors, you guys like doing surgery because you make money from it." Well, that's not true. Because we don't like doing surgery. We want to do it once and do a good job once. And so when these patients with ARD have to come back and have surgery again in the sphenoid and frontal that I didn't open up in the beginning, I feel miserable. And so now I tell patients, if you have ARD, I'm going to open up your whole sinuses, because you may not need it now based on the CT imaging, but in the future, you're going to need it. And so I know that's very controversial, but it's kind of similar to what you were saying, so you kind of predict. So you look at those different biomarkers that we can. I'm not sure if you guys do FeNO. I love FeNO. I think FeNO is a very good predictor. Do you guys measure FeNO? Well, okay, so FeNO is the fractionator of forced exhaled nitric oxide. And so we did a lot of work with that at UVA with Ben Gaston. And then I continued a lot of the work and been working with Brian Lipworth from Scotland. But the person who really helped me understand the disease process really well for FeNO was Ian Poffer from Oxford. And so we were giving a lecture together in Mexico, and he was talking about, he was saying, like, how do we know where these patients are and where does FeNO fall in? Because I like FeNO, partly I'm very biased because I do research with FeNO, and we're doing research with NNO as well. And so I'm very biased. And if you ask allergists, they'll say, if they have a FeNO machine, they say, oh, it's great. If you don't have a FeNO machine, it's horrible. And so, and it was just very mixed messages. So, but the person who really clarified it was this lecturer. And Ian said, if you have high eosinophils and high phenol, doesn't mean you have bad asthma now, but it is a good predictor you're going to have asthma down the road. So these patients with high EO and high phenols are going to be the biologic users 20 years from now. And he showed several cases of that. And he calls it hot, hot. So high EO, high phenol, hot, hot. So and I think a lot of the people in the audience, and including myself, was going like, huh, like, how does that make sense? So he said, well, let me say it another way. If you have high blood pressure and high cholesterol, does that mean you have coronary artery disease now when you're 25? The answer is no. But when you're 50 and you had high cholesterol and hypertension the whole time, are you going to develop coronary artery disease and die of a heart attack when you're 50 and 60 if it's not controlled? The answer is yes. And I think the eosinophils and phenol kind of do the same thing for asthma. And so I'm wondering, is it also a same predictor for nasal polyps as well? If there's a lot of correlation between asthma and nasal polyps, is that the same thing? And so so I think what you're saying is exactly right. That's very forward thinking. And I think is a little bit unconventional. It may not be the standard of care now, but I'm hoping that with more research, it may be the standard of care in the future. Yeah. Well,
Thank
yeah.
you so much. I wanted to ask you, what do you think about the mixed inflammation?
Yeah.
It's been more talking about the asthma inflammatory disease.
Yeah.
What do you think of that? And the role of anti-alarmists.
Yeah. So you're going to get me in trouble, but I will say this. So the answer is, actually, I think that we have not done as good of a job as otolaryngologists in treating sinusitis very well. And as otolaryngologists, we're kind of partly, medical physicians, and we're also surgeons, but I think we're more surgeons. If you ask me, I'm more of a surgeon than I am a medical. And, and actually, we're, so I'm giving, so like Pete Batra, Raj Chandwani, me, and Rick Sandra usually have been giving this mini seminar at the Academy every year. And we were trying to decide what to do. And I think it was Raj Chandwani who tried to insult me and saying, Joe, you're no longer a surgeon, you're just a medical doctor. And I'm thinking, like, I know you meant that as an insult, but to me, actually, it's not an insult because, I think, until the biologics came around, we didn't really have a new class of drug. Now we have a new class of drug, and we're only looking at nasal polyps. But is there medical treatment for CRS without nasal polyps that are more neutrophilic based? And the answer is absolutely yes. And I can't talk about it, but we are working with small companies that are looking at these neutrophilic based inflammation and trying to control that. And so, yeah, I'm fine with using medicine to kind of control the inflammation, whether it be driven by type 2 inflammation or non-type 2 or type 1 or type 17 inflammation. And we haven't done as good of a job. But fortunately, I think a lot of industries have started realizing, okay, there is a role for this, and the people will use it, and that there's an unmet need for it. And so now people are investing more money in it. Yeah.
I know we're running out of time, but this is just a thought of mine. When I see patients with nasal polyps, and when I first operate on them a couple of times, a lot of times they're like watery polyps, etc. But it seems like the magic number, at least in my practice, is number 5. Something happens and they're real fibrous and bloody. Do you think there is a possible shift in the interleukins, or why do you think they've kind of changed their quality?
Yeah, so I think that's a great question. I see the same thing. And so, I wonder if it's the size of the polyp or how long they've had it. Because the longer you have it, the bigger the polyp. And so what we're finding out is that when they're early on, you can do intervention and the polyps just shrink and disappear. So like, I don't tell you to do this. I won't tell you to do this, but Andy Lane from Hawkins said, oh, I give them steroids for 3 months. The polyps disappear completely. Horrible idea. Don't do that. And so, they'll probably have Cushing disease or whatever, but so don't do that. But he's right. If you give them steroids, a lot of the polyps will disappear, but not all of them. And I think it has to do with the fibrin deposition and whether or not it's mature and the tissue plasminogen. I think that really plays a role. And so by having that tissue plasminogen and breaking down the fibrin that's not mature, the polyps will disappear. But if the polyp is very fibrous and they're old, no amount of treatment, not even 3 months of steroids will make those polyps disappear because it's got that fibrotic picture and it's less edematous and it's hard to break down all of it. So I think it's what I call a mature nasal polyp or yeah. Great. Any other questions?
Hey, Joe, it's a quick comment and a question. It's Raj Sidwani. Good to see
Hey,
you.
Raj.
I would have been there in person, but I retired a couple months ago. I don't know if I told you.
Oh, yeah. I know you're old like me, Raj. That's why.
So thank you so much for the talk. That's always super interesting to review all that immunology. And it shows too, like how our evolution of thought has been as we gain more and more understanding of the underlying mechanisms, and then also as we get more tools. So I might push back on the eosinophil comment just because, unfortunately, current state minus the biologics, anyone that has significant nasal polyp disease is going to get treated with steroids afterwards, anyways, regardless of your eosinophil count. So I don't know how practical that would be to measure in everybody. But my question was actually towards biologics. And I know we're going to be talking about this in our panel in a week or two, but can you give us a sense of when you're using the biologics as far as polyps and the relationship to surgery? So obviously we've had several position papers out saying, we all think, and I'm asking if this has changed in your experience more recently, that everyone deserves one thorough surgery before you turn to any biologic. Interestingly, all of us have also had the experience where someone got a biologic maybe before they had surgery or never had surgery and have had robust responses to it. So how do you reconcile that? And what's your kind of step-by-step paradigm for when you'll operate and when you'll turn to a biologic?
Yeah, thanks, Raj. And so, hey, that was you saying that I become a non-surgeon, right? Or was that Pete Batra? I don't know.
Definitely me, but it's not meant as an
All right. Yeah. And so thanks, Raj. He's always very supportive. I'm sure he's like that with you guys too. But so for the blood eosinophils, I would say I'm going to push back on that. And yes, if the blood eosinophils 300, 600, not that big of a deal. But once you start having a blood eosinophils higher, like 1,000, all of a sudden, if you have a blood eosinophils greater than 1,000, if you have asthma, you have to start thinking of other eosinophilic disease like EGPA. And so so I would draw P-ANCA and C-ANCA on those patients to rule that out. By definition, if you have a blood eosinophils greater than 1,500, you got to start thinking of, by definition, they have hypoeosinophilic syndrome, right? And so you have to rule it out and see, do they really have eosinophilic inflammation? And if they do have these other eosinophilic disease, which are not that common, but still we see enough of them, it will change your treatment options. So I'm going to push back on the blood eosinophils. I do think it's important. Number two is, I would say you're absolutely right. We did this, and you guys, I don't know if you guys read the paper, the multidisciplinary treatment approach or algorithm for nasal polyp. It was a group of it was different representatives from the ARS, the American Academy, the college, the QuadAI, the AOA. And it was a mixture of allergists and ENT doctors, and we all agreed that, and everyone I asked, all the different experts who deal a lot with biologics, all say exactly what you said. If you have nasal polyp, you never had surgery, one good sinus surgery, really one good surgery, not the poking a hole in the ethmoid bulla, but like one good surgery. And if they fail, and this is where Adam DeCon paper is kind of so relevant. When he wrote that paper, I thought it was irrelevant, but after I read it, I realized there was no other papers that really talked about it. So I thought Adam's paper was really good. And what it showed that a lot of the patients, even with good sinus surgery and good medical treatment, pre-biologic, the chance of the polyps coming back is like 40% or maybe even 50%. And if you look at who these patients are, these patients usually have comorbid asthma, right? And so, and if they have comorbid asthma or ARD or aspirin triad, these are the patients who are going to need something more than just topical steroids and oral steroids. So they're going to need something more. So I completely agree with you. I think the consensus is still the same. You know, do surgery if you've never had one, and then consider a biologic if the polyps come back, and you're having a hard time treating them. Definitely consider other options that are not steroids, systemic steroids at least. All right, great. All right, thank you.